रेडी है? करूँ स्टार्ट करूँ? Okay. Good evening friends and welcome back to the Thursday evening PG teaching session brought to you from Sion Hospital, Mumbai. As we have been mentioning in the last 2-3 episodes, the hall where this class is being conducted is under renovation. So this is the recorded version which you are seeing. All Mumbai students are invited to attend the class physically, and we will inform you once the live relay restarts in a few weeks. We thank the authorities at Sion Hospital for allowing us to conduct these classes and to Aristo for an academic grant. Today we have two cases. The first case is being presented by Dr. Pankaj from Sion Hospital. So we start with that case.
Uh, 11-year-old boy, first by birth order, born out of non-consanguineous marriage, resident of Dharavi, hailing from Maharashtra, Hindu by religion, Koli by community, brought by mother with complaints of fever for 4 days, 8 days back, and swelling of bilateral lower limb since 4 days, and rash over the bilateral lower limb since 4 days. Patient was apparently alright 8 days ago when child developed fever which was high grade, associated with chills and rigors, intermittent, relieved on medication, active during interfebrile period, associated with throat pain, not associated with any myalgia or retroorbital pain. For above complaints, the child was taken to private practitioner and received some medication and fever subsided. 4 days later, mother noticed small purple reddish, well-defined rash over the left leg and edema simultaneously developing over the feet. Rash gradually increased over the last 4 days, involving the bilateral lower limb, gluteal region, lower back and bilateral upper limb. Was taken to a hospital, admitted for 3 days, where he received injection ceftriaxone, omnacortil and cefixime. Next day, edema and rash increased, involving bilateral lower limb and upper limb. This was associated with bilateral knee joint and right-sided elbow joint pain and swelling and difficulty in moving the joints. There was associated pain and difficulty in walking. There was no history of abdominal pain or distension or edema elsewhere in the body. No history of decrease in urine output. No history suggestive of cardiac or liver disease. No history of blood in urine or burning micturition. No history of bleeding from any other side. No history of insect bite or any significant drug intake prior to rash. ANC history, no history of any significant maternal comorbidities. Birth history, it was full term LACS in view of CPD. Birth weight was 4 kg. No history of any NICU stay. He is immunized till date, and the dietary, he is taking mixed diet. It's from family pot. He belongs to upper lower class according to modified Kupuswamy scale.
Okay. Second. Okay, so what do you make out of this?
So, sir, child is presented with fever, swelling, and rash. So, sir, I would like to ask, so how the rash?
Only this. Only this. Rash has not yet come.
So sir, so if it's simply fever, if I take this into account, the fever, so sir, since it is associated with chills, rigor, high grade, so I would like to, I would like to think in terms of any urinary tract infection or malaria.
Okay. So now 3-4 questions. See, later this case is looking easy. So let's get our basics clear again. So first question is, chills and rigors is same or different?
Different.
What is the difference?
So rigors is because of muscle contraction, and such chills is subjective feeling of like cold.
Very good. What is the interpretation? Does it help you in diagnosis?
No.
Okay. Now you said malaria and UTI. So anybody wants to fight with him that this doesn't look like malaria or UTI, or you all agree that this is malaria and UTI?
Associated with throat pain, might be tonsillitis also. Let's see.
Sir, any high-grade fever can have chills or...
Agreed. What I'm asking is that anybody who comes with fever with chills and rigors, will you think of malaria or you want to get deeper into that? So what is that deeper? What do you want to know? Which will tell you that this person with fever with chills and rigors is malaria, and this person with fever with chills and rigors is unlikely to be malaria.
Sir, repeated paroxysms of fever, the type of fever, like if it is benign tertian, like occurring every third day.
Okay, so if you are lucky and if that pattern is there of every second day or third day, which is not very common in practice.
Sir, a sick-looking child, the condition
Malaria
of...
is sick looking or fine in between fevers?
In between, fever is fine.
Okay. What about UTI in a 8-year-old?
UTIs in 8 years old are slightly less likely.
Okay.
It's more common in early childhood.
Okay. If a 8-year-old gets UTI, what else is likely to be there in the history?
Burning micturition or discomfort during
So
urination.
first of all, it's likely to be lower UTI rather than upper UTI. Or then there is a big past history of repeated infections or something like that. Means if there's some congenital abnormality or whatever, right? So that's odd for it to be UTI. Also, he's a boy. He's a boy. What about, so you said throat tonsillitis. So can this be tonsillitis?
It might be, one of the findings might be there when we examine the child.
See, why we are spending time on all this is that what this case turns out to be, you will see once a year in practice. But this slide you will see every day in practice. So you should be very good with this slide, right? So now, suppose this is tonsillitis, what is the detail that you want which will tell you, yes, this can be tonsillitis? How bad should be the throat pain? We're talking of classical, then there can be variations. How bad should be the throat pain? Severe throat pain. It should be one of the chief complaints. Then when should it start? Fourth day, here we don't know when it started. First day or fourth day.
The child will rather come with throat pain only. He will complain of throat pain like it as a prominent symptom. Had it been tonsillitis, and in between he'll be all right. The fever spikes, but throat pain will be persisting.
What else do you want to know which is probably not there in this description? It's been 4 days. So is 4 days a turning point for something?
Localization of symptoms usually
So
starts.
localization apparently throat pain. What else? So what happens to viral infections on day 4? What happens to bacterial infections by day 4 which are untreated? What happens?
A viral infection will child will get better by day 4, and bacterial maybe will be more
Get
sick.
worse. So you want to know the trend of the fever, whether it's getting worse, getting better, right? Sir, anything to?
So I think we have already discussed this problem. Fever is 100% viral mostly, and there are enough reasons. Okay, so you all know that very well. Self-limiting, interfebrile period, fairly normal, a poor localization. This is not a localization. Whenever you have a throat pain, you need to ask how severe is the pain? Is there a difficulty in swallowing? Has he been swallowing? Has he been feeding? Has he been drinking, eating? All that becomes important. Even a viral pharyngitis, the patient will say, yes, I think there is some pain. But there is a difference between, we must have learned this in the first clinical term in undergraduate. When there is a pain, ask site, how severe, aggravating factor, relieving factor. We all learned that. But we have overcome that and we say pain is pain, now that's enough. So this is obviously a viral infection. Now, why is viral infection after fever has disappeared coming out with a rash and swelling of the legs first? And then it spread. If you were there on day one, when he came saying that, like fever has gone, but today I have on one foot some rash and some swelling. Again, we need all the details. What kind of rash on the history? Then what kind of swelling? Is swelling restricted only to one leg? Okay, how severe is the swelling? If there is a swelling, the next question is, this child, to begin with, we have always been saying, first statement in any history is, have you been totally all right prior to this symptom? If you did not ask that, we are not sure whether he is a malnourished child and a simple viral infection of 3-4 days is coming out with a subclinical hypoproteinemia manifesting. That would have been my first thing. Okay. So, point is, why rash and swelling? I've seen many rashes without swelling, and you have seen many swelling without rashes. Can you tell me why should a rash and swelling come together? Some thought. Rash and swelling.
Inflammation. Aggravating, like inflammation might be aggravated.
So is the rash responsible for swelling? Is swelling responsible for rash? Or there is a common pathogenesis which is responsible for both? Straight away, these are the three possibilities. Can rash cause a swelling? By itself, no. Can a swelling cause a rash? Probably no. So there has to be a common pathogenetic factor which is resulting both in rash and swelling. Which must be that?
Vascular involvement.
So simple. Okay. This has to be a vasculitis. Okay. So we have already got that on. Now, post-infective, self-limiting infection, so we called it viral, and now vasculitis. Okay. Where is this likely to lead to? You're on day one of so-called suspected vasculitis. At that stage, what questions would you have asked to make sure that this vasculitis is only local or peripheral and not anywhere else also? What questions would you have asked? That's the way you anticipate the problem, and you could have told the parents, then they would have come and say, yes, now that you are asking, I know that, yes, there was this symptom also, which they could have easily overlooked, or they thought it was not very certain. So which symptoms would you have asked the patient when you suspected vasculitis, whether it's a local or a general problem?
Joint pain.
Joint pains. Anything else?
Very good. Joint pain. What else? In other words, every organ. Every organ. Joint, of course. but every organ. You don't know where it is moving on to. And we do not know whether vasculitis is primary vasculitis or it's a combination of multiple rheumatological disorder. We have no idea. But joint first. Which other organ comes the next or equally important in vasculitis? Intestine, severe abdominal pain. Okay. Thereafter anything and everything.
Renal, then renal. So basically vasculitis, there is edema of the, we won't know it's edema involving the joints also or it's only a subcutaneous edema. So if you ask how is the movement painful? Just if there's subcutaneous edema, movement should not be painful. But if there is pain on movement, that means you know that it is involving joint also. So we go a step further, vasculitis involving joints. So then we think of different vasculitis syndromes where joint is involved. Even if there is no direct involvement of joint, still we are at a vasculitis with edema. And then we see further, is there any involvement of renal? That means hematuria, maybe painless hematuria. Abdominal pain. I must just point out, often when there is abdominal pain, one cause of abdominal pain which we often forget is vasculitis. Okay? There is ischemia and we think of everything but we don't think of ischemic pain in abdomen, and it can be troublesome and serious. And of course other organs, usually pulmonary manifestations are not there. CNS manifestations can occur but not very common. Hypertension can occur and therefore other problems related to hypertension. But vasculitis and related complications, post-infections, because 4 or 5 days have gone. Then you may ask about a little more about the rash. Okay? What would you like to have, ask about the rash? If possible, if they know. What is the color, what is the color of the rash? Is it blanching?
Painful or
Okay, painful rash less likely, but after, if they know that it blanches wherever they hold the child, suppose, and that area there is blanching and color of the rash, because the color may actually suggest some very serious disorder. And what could that be?
HSP.
Pardon me?
HSP.
SSP is still
HSP, HSP.
HSP, yes. Much more than that. So rash is whether it is purpuric. So we'll ask the color of the rash. Is it purple in color or no? Anything, whenever there is a purple rash, the antenna should be up. If the child has fever, no fever, what can it be? This is just a training for us. Any purpuric rash, I think of a serious disorder is associated with fever. What could that be? I only
Associated with fever,
a fever and purpuric rash.
like meningococcus.
Meningococcemia. I don't have much time to treat. If I don't act early, I have lost the battle. So we think of there is rash, distribution of the rash, color of the rash, organs involved, all those things we will ask. So it seems here that it's vasculitis. Was the rash purple in color? It was purple in color. So probably purpura. So vasculitis, purpura, not thrombocytopenic purpura, probably not, because there was evidence of vasculitis. Of course, palpable purpura or no, we don't know on inspection. So this is how we are proceeding toward anaphylactic or allergic vasculitis and edema. So far no involvement of joint or kidney, but we'll know further.
We know it's a purpuric rash. Okay, why don't we think about a bone marrow disease? Much more common than vasculitis. Okay.
And we started with fever and throat pain. So why not streptococcal toxic shock syndrome?
Because you can get thrombocytopenic purpura and varieties of complications. Okay, DIC, sepsis, toxins, it could be any one of those. So how are you sure it's vasculitic purpura?
But for all those, the child would be very sick for DIC, shock sepsis, even streptococcal toxic shock syndrome. It would be a sick child. And rapid progress.
Yeah. So you need to confirm on history that he's otherwise not so sick. So that rules out that bunch.
And most important is, every other purpura does not have edema. That edema brought us to say it's a vasculitis. Otherwise, rest all causes of thrombocytopenic purpuras are gone, just because both have come together. Okay, unless one was of different etiology than another, but this child did not have any other story to support that. And therefore, edema plus purpura is a vasculitis still put otherwise.
And added to that is the word anaphylactoid, because allergic. So we're almost giving the diagnosis.
Your negative history has almost ruled out vasculitis everywhere. Very good. That's a good thing.
The child is here.
Yes, sir.
Call him. Chal, come, two of you come and tell us how you examine him. Chal, come.
Well-grown, non-sick looking boy. Well-grown, non-sick looking boy, comfortable, with rashes, predominantly in the lower limb. Some rashes on the abdomen also, abdomen and back. Non-blanching rashes, non-palpable, violet colored,
Edema, bilateral.
bilateral edema present. And no rash over face, chest. No rash over the body and not painful.
Warm on touching both
Warm on touch. Where?
bilateral, lower limb.
The whole limb is warm.
No,
Generalized warm.
Huh?
Generalized,
Generalized.
normal temperature. Not,
Not warm or warm?
there is no increased warmth.
no local rise in temperature.
What else? Any joint swellings?
No joint swellings, no knee effusion. No knee effusion, no joint swellings.
What else is important on general examination? Is there pallor?
Some pallor is there, otherwise no severe pallor.
Okay. What else is important on general examination?
Whether any lymph nodes present or not.
Very good. So lymph nodes. Now in exam, don't examine this way, otherwise you will fail. So keep both your hands free, keep everything and then examine properly. What else on general examination? General examination.
Redness of eyes or any visible like uveitis or
So how do you know there is uveitis now, acute uveitis, and how do you know there's chronic uveitis?
In acute uveitis, there will be pain, redness, and photophobia.
Okay. Chronic,
In
cold.
There will be circumcorneal congestion present.
In chronic uveitis, you'll get circumcorneal congestion.
There will be redness.
There may be, it is not there will be. So what are you looking for which will tell you that he may have had a uveitis earlier?
Some hypopyon or
So some adhesion, some irregular pupil, something where you find a cicatricial scar or something which will tell you that there was inflammation earlier and healing. Okay, then you want to look inside the mouth, general examination. What do you want to look at?
mucosal lesions. Any mucosal involvement present or not?
So mucosal bleeds.
Bleeds.
Okay, and ulcers. Okay.
Anything else with help of some instrument? Part of general examination which pediatricians don't do.
Throat examination.
Blood pressure.
Look for hypertension.
Hmm?
Look for hypertension.
Okay. Fine. Now, anything else is there on examination in this child besides what we discussed?
Gluteal region is also involved. There is a rash over the gluteal region, and there's upper limb also involved.
There is slight desquamation of the palms present.
Sorry?
Desquamation of the palms.
Okay. Fine. So now what's your diagnosis?
Is his blood pressure okay?
What's his BP? Sir,
99 centile. Is that normal?
BP is 130 by 90 at a 99 centile.
So is it hypertension?
Yes.
Yes, sir.
What do you think? If it's hypertension, then there is a renal complication occurring.
Small vessel vasculitis involving renal.
Sorry?
Small vessel involvement involving kidneys also.
That's what sir is asking, that would you say that kidneys are already involved, or how would you react to this BP?
Hypertension in this condition is suggestive of involvement of BP.
Correct, but is this established hypertension? So first step you would say is probably you would repeat the recording again on 2 or 3 occasions, confirm, and then take it forward, right? Okay.
Can pediatric patients have an essential hypertension? Adults, the commonest cause is essential hypertension. I don't know why they call it essential. Who has a hypertension essential? But somehow that statement has been always made. Okay. So when does an adult essential hypertension start in life? Does it start at 40, 50, 70, 80? When does it start? And the answer is it may start in pediatric age group. And in some of the Western countries, US of course is very aggressive. Every year routine check includes blood pressure in all children. And the British Pediatric Association expects every 5 years, okay, a blood pressure check. Because he may have started with 25th centile, and then he became 50, 75, now he is 99. So he may be going in for a slow worsening, which will be called as an essential hypertension when it becomes symptomatic. Now the question related to that is, if you were monitoring the blood pressure and saw that his centels are going up, could you have stopped it from going? Or you would have said, you are unlucky, you are going to be hypertensive. Can you do something? You sit down, sit down. Can you do something for such a slowly worsening blood pressure? Not still hypertension, but certainly going up the centiles. What could you have done? Give a thought, not difficult. Nelson will not give this. Give a thought.
Child is not hypertensive, but he has BP reading in the 58 to on higher side more than 58th centile. Then it is we should do some changes like preventive measures, lifestyle changes, exercise. And if it is going on higher side and associated with renal involvement, then we may need to start him on medications.
So the answer is, how do you treat essential hypertension in an early stage? Weight control,
Salt restriction.
okay, diet control, exercise, okay, lifestyle changes. And we would have started doing that right from then. Okay, and that's important. As much as the growth charts are important, in Western countries you also monitor the the blood pressure, whereas most of us take blood pressure only when you have a cardiac or a renal problem or some suspected thing. But that is important. This 99 was made. Now looking at him, do you think he is overweight? Possibly he is. Okay. So is that the reason why he's going to? You could have asked the family history of hypertension. So he has a genetic propensity, okay, increasing in weight. The most common cause of obesity today is the electronic gadgets, cell phone, etc. So ask him whether he's doing that. And poor exercise, all that could have been done. Same way, when you see such an obese child, you should examine his neck. Very good.
Acanthosis nigricans. So it's a cutaneous marker of insulin resistance.
Forget, he might be a...
How does it look?
Black velvety appearance.
Velvety feeling is important. Black pigmentation is not uncommon, but not all of them will have velvet. So feel for velvety. That's important.
So possibly look at that also in this child. That means that blood pressure and a probably pre-diabetic state could go together. And I think that is what you want to pick up. 99th is not called normal. 95% is okay. 95th centile is okay. 100 and more is abnormal, but in between is a caution. And as he said, first recheck several times. Okay. If while checking he is anxious, he is stressed, his blood pressure is going to be a little higher. Okay. And I think that's why recheck few times is important.
You want any other finding is there? You want to run through your findings?
Maybe I'm imagining, do you think his cheeks are little fuller? Do you think he has been on steroid for some time?
Sir, in that hospital he was given.
Oh, he was given.
He was admitted somewhere, so ceftriaxone, omnacortil and something else.
But if there was for short time, probably not. But
Yeah.
here I don't know whether he is on steroids.
Aja.
Anthropometrically, he falls under overweight. Head-to-toe examination, there is no pallor, icterus or cyanosis, clubbing or lymphadenopathy. Upper limb, lower limb and gluteal region has a palpable purpuric rash. Lower limb, there is a peating edema present. And on throat examination, appears normal with no congestion. And on local examination, there was bilateral knee joint swelling present, normal in appearance, warm to touch, and restriction to range of motion was present. There was no tenderness, and the rash was present over the bilateral lower limb, gluteal region, and the bilateral upper limb. Multiple in numbers, reddish purple in color, palpable, and painless to touch. And all the systemic examinations within normal limit. So, my impression, 11-year-old boy, first by birth order, born out of non-consanguineous marriage, with complaints of fever, purpuric painless palpable rash, and swelling over the lower limb, gluteal region and upper limb, with hypertension. I would like to keep the following differentials: acute febrile illness, small vessel vasculitis, or secondary to any drug reactions.
So how will just an acute febrile illness explain everything? You said your differential is acute febrile illness. So what kind of acute febrile illness? Means acute febrile illness is a diagnosis, or it's just one part of the story?
It's one part.
Okay.
Why do you say small vessel? Vasculitis is vasculitis, no? Why small? Small is what? Less serious? Medium is more serious? Why small vessel vasculitis? I would have been happy if you said vasculitis. Don't you agree? You don't say small pneumonia, moderate pneumonia, whatever, no. So why small vessel?
So what is the meaning when we use that word? Sir is asking.
So is there any big vessel vasculitis?
Small vessel is basically for the arterioles and the capillaries.
Of course, small, medium and big tell you where to look for further, I think. Okay. And what is Kawasaki? Small, medium or big? Big? Medium? Why?
Involves the coronaries and
So the
medium
medium-sized vessels are involved. Okay, fine.
Why is this not just ITP? Clinically, all you've got is purpura. Suppose you ignore the history and you have this patient in front of you. Why is this not ITP?
Pattern of distribution, predominantly lower limb with edema.
So predominantly lower limb, as in he does have on upper limb also, no?
Very little.
Huh?
More on lower limb with edema.
Okay.
Come more with petechial hemorrhages or ecchymosis.
So petechial hemorrhages are there. These are petechiae only, no? Ecchymosis are
no
not
other
there.
mucocutaneous involvement. No other like mucocutaneous involvement apart from.
So mucocutaneous involvement is pretty important. That is one. Of course, these other points are also there. Right? Okay.
Will he have edema if he has ITP?
No, they said edema, they said.
Yeah. And does he have arthritis? I mean, does he have joint in? You said that there is no pain, but there is swelling of the joint and movement restricted. So does he have or does he not have arthritis? Why there is no pain if you say is arthritis? And why there is restriction of movement if you say that no arthritis?
I think what they meant is evolution. At one stage he had and now he doesn't. Okay. So how will you investigate him?
Sir,
Mike.
we'll do the inflammatory markers.
Have you done any investigations? Show.
The ESR is raised 80 mm per hour. CRP is raised.
So what?
30.
What does that tell you? Means we are just revising. So suppose ESR is raised and CRP is raised. What does it tell you
There
in
is
this child?
Inflammatory changes, like there is arthritis and also there is inflammatory changes.
Suppose it was not raised. Active inflammation. Suppose it was not raised, would it have gone against the diagnosis of HSP?
No, sir. No. It's a clinical diagnosis. So.
Okay. Then go on.
Total BILI is 0.3 and SGOT, SGPT is 36 and 36. Alkaline phosphatase is 167, which is slightly higher. Total protein is 8.6 and albumin is 4.1 and BUN creat is 11 and 0.7.
Why is the
comment on total proteins and albumin? What is albumin globulin ratio here?
It's reversed.
So has the albumin gone low or globulins have risen?
In this case, globulin is more.
Can you explain that?
Yeah, there is a reversal. Okay, reversal is classical in nephrotic syndrome. So this vasculitis is possibly damaging the kidney also. Reversal, no? Look at a book, typically reversal of albumin globulin is nephrotic syndrome. Is it not enough to say that I should do a kidney biopsy? I may not have oliguria, there is edema, there is a reversal.
Nephrotic has hypoalbuminemia that leads to the reversal. Here the globulins are increased.
So reversal is because of low albumin and normal globulin, and here the albumin is normal but the globulin are raised. So this is not the reversal that we know of that, and therefore this is reversal all right, but not related to albumin. Then why is it there? Globulin should have been a 2-to-1 ratio. No? This is almost 1-to-1 or even 1-to-1.2. Why globulins are raised? Come on, you know it. Simply because it's an immunological disorder, no? Okay.
Increased gamma globulin.
And therefore, antibodies are involved somewhere, either in an antigen-antibody complex or antibody itself. Therefore, a good way to pick up an immunological disorder, like if you had an inflammatory bowel disease, okay, there could be something similar. There, even albumin may be a little low and the globulin may be even higher. So that is another sign of an immune-mediated disorder, antibody-related.
So that reversal is typically to be seen when the total protein seems normal, but the intra-distribution is reversed. In nephrotic, your total protein only is low, so there is no question of talking about reversal, right? So when the total protein is normal, but albumin is less and globulin is more, it means that either albumin is being synthesized less or globulin is synthesized more. So this is the second case where globulin is being synthesized more. Why skin biopsy?
Sir, for confirmation, like in diagnosis, it will help for leukoplast.
How?
There will be leucoclastic.
So what is the new name for HSP?
IgA vasculitis.
IgA vasculitis, right? So it's no longer called HSP, it's called IgA vasculitis. Now, you showed us, what a platelet is 373. Okay. Fine. Anything else you want to do in investigations? Something which is missing important. You don't want to do urine routine. You have to do urine routine, no? So what is the urine routine?
Sir, 2 to 3 parcels.
What are you looking for? Proteinuria, microscopic hematuria. Okay, so urine routine is very important. Okay. How will you treat this child?
Sir, symptomatic management only for this child. There is
What is the long-term prognosis? Will he be fine? Will he have kidney damage? Will he have any other complications? So by and large, long-term prognosis is good, but not 100% of them have good. So some of them can be, there can be a renal residual this thing. Can it recur? Do you have something like recurrent HSP? It can, not very common, but once in a while it can recur also, right? Okay. Fine. We move on to the second case for today.
Yeah, I want to tell you out of the box things. When you think of vasculitis, you can see the vessels in the eye. How many of you own an ophthalmoscope? How many of you own an ophthalmoscope? None of you. You get stipend, right? Buy it tonight. You get a big boy, he has got glomerulonephritis or any vascular disease, and you tell your examiner, I have seen fundus, and it shows vessel damage or whatever, or it doesn't show, you have passed your exam. Number one. Number two, in UK, we have a growth chart, right? So they have a BP chart. Have a look at the net. And they say that if your BP is up by 5 from your baseline, if it is above 10, you need drugs. If it is above by 5, you need non-pharmacological care. Number 3, Maharashtra is a very good god, Vithoba. He has got a thin waist. So we remove the shirt and see the waist. If the waist is not thin, he is obese. And if you add that, you score more. Thank you.
The biopsy showed something? A report is awaited.
Do you have a copy? It's very good for passing exams. Rash 3 rings. You make them by heart. If there is a 4th one, you have to refer it. That sort of thing. It's a very nice thing.
Good evening. Good evening, sir. Presenting today's clinic. So, sir, I have 5 years old boy, first by birth daughter, born out of non-consanguineous marriage, hailing from Gujarat and resident of Malhar, Muslim by religion, brought by and informed by mother, reliable with the complaint of spontaneous onset ecchymosis since the last 4 days. Child was apparently all right 4 days back when he developed vomiting, 3 episodes non-projectile, non-bile stain, non-bilious containing undigested food particles. For the above complaint, the parents took the child to a local practitioner wherein some oral medications was given for vomiting and the vomiting resolved. The next day morning, the parents noticed that the child developed spontaneous onset ecchymosis, initially on the lower limbs, and then it spread to involve the forearms and the cheek. The size was approximately 1 to 2 centimeter. The color was initially red and then it turned bluish black, not painful. No history of bleeding from any other side, jaundice, any prick site bleeding, preceding sore throat or fever. No history of any blood disorder in family, abdominal pain, gum bleed, bony pain, any history of trauma. These are more or less spontaneous. Any similar illness, any eczema, any skin itching or recurrent infections, and no history of any past hospitalization. Birth history, ANC history wise, nothing contributory. Registered pregnancy at 4 months period of gestation. Booked case, CVST done thrice, all were told to be normal. And a mother had taken both multivitamin supplements and tetanus toxoid. Birth history, child was full term, normal vaginal delivery, weighing normal, cried immediately after birth, and no NICU stay was there. Discharged on day of life 3. Child is immunized till date. Developmentally, he takes tuition classes, is age appropriate. In dietary history, he takes mixed diet from all the food groups. Total calorie intake is 1250 kilocalorie, and total expected energy is 1250 kilocalorie, and protein requirement is 22 gram, and he takes 1000 kilocalories and 20 gram of protein. He is the only child to his father, who is 29 years, and he is a taxi driver, and mother is 25 years old. No other sibling and no family history of blood disorder.
So how do you analyze this?
So spontaneous onset ecchymosis, no history of trauma. So this is some sort of bleeding disorder. So next I'll go into whether it is platelet disorder or coagulation disorder. So if these are spontaneous small vessel bleed of platelet, this will be more subcutaneous, like petechial hemorrhages. And if it is of coagulation factor, then this will cause more of joint bleed, hemarthrosis, or venous bleed like hematemesis.
Okay. So, but ecchymosis is common to both, no?
Yes,
Coagulation and platelet. So can this, what is this according to you?
So this is according to me platelet disorder.
Why?
So coagulopathy will be secondary to like liver disease. And
it can be congenital, no?
But sir, then this would have presented much earlier.
Not necessary. Depends on the severity of the illness. If the factor levels are not very low, it can present later.
Ecchymosis is common in both, but dash is common in one only.
Petechial hemorrhages.
Purpura is seen in platelet or vascular disorder, while ecchymosis is seen in both. But in coagulation disorder, you won't get purpuric spots.
Can this be drug induced? Vomiting, then drug taken, then this has started. There is a clear history, no? He had vomiting, some drug was given, vomiting stopped, next day all this came up. So this is drug induced.
Like the drugs causing drug-induced thrombocytopenia usually are like anticonvulsants or some antibiotics. Unlikely any medication for
Antiemetic.
vomiting.
Okay. What else? So that's one point. What else? Part of the answer is in your what you said just now. So after a drug, what kind of rashes can you get?
Fixed drug eruption.
Huh?
Fixed drug
So what
eruption.
is a fixed drug eruption?
More around the lips.
Yeah, but that's the site. But what do you mean by a fixed drug eruption?
Like allergic.
Color.
How does it look like? Is it there all over the body?
No.
Do you get 50 fixed drug eruptions?
Bluish purple color.
Yeah, so the color may look similar, but you will have one or two places where you will have that kind of a patch, not all over the body. Okay? Then the anticonvulsants which you said, if they cause thrombocytopenia, then there would be a purpuric rash, not a ecchymotic rash. Right? So that's the second. Then what else can a drug cause? Are these the only rashes a drug can cause?
Stevens-Johnson syndrome.
Stevens-Johnson. So you could have mucocutaneous manifestations, generalized erythema. So different morphology of rash. So this kind of a description of ecchymotic patches is very uncommon for a drug. Right? So that's why not a drug.
And maybe for drug, means thrombocytopenia drug induced, it's little too soon.
Too soon, exactly.
Only 3-4
Yeah.
days have passed.
I will give you a clue to what I'm going to talk about. What's the commonest cause of epistaxis in an older child? Commonest
Nasal.
cause.
Due to nose picking.
Nasal picking.
Commonest cause is fragile capillaries in the nose. Okay, there are people. Yes, and there are people who extreme cold, extreme heat, they would have a bleeding, unilateral. You just press it, they are all right. They don't even need investigations if you are sure what you are doing. Can ecchymosis be due to fragile blood vessels? In the nose is very common. But what is common between fragility? Can my blood vessels under the skin be also fragile, that they easily bleed and cause ecchymosis? And that happens with some connective tissue disorders. Okay. And which are those? Ehlers-Danlos.
Ehlers-Danlos.
Okay. Where there is a abnormal connective tissue, so even a blood vessels take the same brunt, and children may come with such. I'm not sure whether the Marfan's also would have something of that kind, but I'm sure Ehlers-Danlos does that. And you look at the skin and you just kind of stretch it, and you know it's very stretchable skin. So keep that in mind. Of course, we have discussed all bleeding disorder. Could it be a thrombocyte, but non-thrombocytopenic thrombocytosis? Non-thrombocytopenic thrombocyte disease called thrombasthenia. Could it be thrombasthenia?
So they will come with purpura, more of purpura.
Okay. And
no thrombocytopenias.
yeah.
There will be past history also. There will be history of delayed healing of wounds if had it been thromboasthenias.
History of delayed healing of wounds.
It may not be so strong a parameter. The point is, thrombasthenia is a apparently normal looking person who has few such ecchymotic spots here and there, and they last long. Okay, they are not thrombocytopenic because you do a platelet count, and then you might consider a platelet function test. Okay, so keep such things in mind, because this ecchymosis is unlikely due to any significant disease of a coagulation disorder, neither congenital nor acquired. And what acquired besides the liver? any other acquired cause of ecchymosis besides the liver?
Scurvy.
Severe sepsis.
Sepsis.
Antibiotic-induced vitamin K deficiency. Okay. Frequent antibiotics, frequent infections, you may have a vitamin K deficiency, similar to what happens in the liver, and therefore chronic diarrhea with antibiotics and a chronic liver disease are acquired causes of that, right?
The thrombasthenia which sir was mentioning is not at all uncommon. They come for easy bruising. Lagta hai, unnecessarily it becomes blue. You do all investigations, they will be normal, platelet count, etc. But if you do special qualitative function defects of the platelet, you will have abnormality. These individuals lead absolutely normal life. Often there may be a history of excessive bleeding during periods in the mother, but she has undergone a normal delivery. There was never any extra bleeding during delivery also, which tells you that it's not a bleeding disorder from that, and it is not uncommon to have this kind of thrombasthenia. Other thrombasthenias which is uncommon is hereditary thrombasthenias. Bernard-Soili syndrome, where you get a giant platelets and they are very sick and they bleed like hell right from the beginning.
So on examination, child was afebrile. Pulse rate was 102 per minute, normal in volume, regular, no radial or radiofemoral delay, normal character. Respiration rate was 26 per minute. Blood pressure was 90 by 60 millimeter of mercury as measured in the right brachial artery in the supine position. All the peripheral pulses were well felt. Anthropometry wise, sir, weight is 17 kg, which comes in -1 to 0 standard deviation. Height is 110 centimeter, which comes in -1 to 0 standard deviation. BMI is 14.04, which is again normal. So on head-to-toe examination, the child was not sick looking, build was normal, he had some pallor, and ecchymosis was present on the extensor surface of the legs, on the flexor surface of the forearm, and he also had minute petechial hemorrhages, but not well visualized here. And on systemic examination, all the systems were within normal limit. In the cardiovascular, both the heart sounds were heard, no murmur, tone power reflex were normal, and there was no organomegaly. And in the RS system, clear bilaterally, air entry was clear bilaterally, and no lymphadenopathy in head-to-toe examination. So I would like to summarize. 5-year-old boy, birth and developmentally normal, immunized till date, presented with the complaint of spontaneous onset ecchymosis since last 4 days, and on examination with normal vitals and no systemic findings, probably a case of acute ITP, and second differential is coagulopathy.
Okay, if it's coagulopathy, which one is it likely to be?
So hemophilia.
Which one?
A.
Why A? Huh?
Male child to hemophilia.
Male child.
Yeah.
So why not B? So actually, as you already said, joint bleeds are a kind of characteristic of hemophilia A. So I would in fact put hemophilia A lower and would think of any other hemophilias, or on Willebrand or whatever, right? How will you investigate?
Sir, we have done. Sir, on CBC, there is the HB is normal 12.3, TLC is 6,800 cells per cubic millimeter, hematocrit is 35.4, and the platelet count is less. It is thrombocytopenia, 7,000 cells per cubic millimeter. So, sir, just hold on. Sir, in this CVC, we have, we could find the mean platelet volume. It was 7.9 femtoliter, that's in the normal range. And, sir, the ANC count was slightly in the borderline area. It is 1,510. So, sir, because of this, some untoward feature in the CBC of absolutely, on the lower side of ANC. So we did bone marrow examination in this case.
Okay, so before you come to that, first tell me, what does the mean platelet volume tell you? What are you looking for and what does it tell you?
Sir, like in ITP, the platelet in the peripheral smear, the platelet size is increased because they're immature platelets. So because of increase in the size, the platelet volume is increased. It reflects the turnover of platelet.
Okay. Then, so on the peripheral smear, what tells you that platelets are being produced normally? On peripheral smear. You don't have all these indices.
Large immature platelet with granules.
So giant platelets or large platelets. That tells you that platelets are being produced normally. In a normal CBC, have you've read, all of you have seen a CBC report from any lab? They report the platelet count and then they niche write platelets adequate on smear. Why they write 2 times platelet? When they are given the count, why should they write adequate on smear?
So sometimes the platelets are in clumps. So the Coulter machine can, the count doesn't show the approximate number if they are in clumps.
Okay, any other reason? Can there be a spurious thrombocytopenia? Means false thrombocytopenia.
Diluted sample might have.
Diluted, okay. More common reason? Madam is giving the clue, EDTA bulb is not shaken, then what will happen? If the bulb is not shaken, what will happen? The blood will clot. There will be microclots. Clots consume platelets. So if your sample has clots, you will have a lower platelet count. But on that specimen, on the smear, platelets will be adequate. So whenever you get a low platelet count reported, you must look at that bottom ka smear, and if that also shows platelets reduced, then the two things go hand in hand. If that shows platelets adequate, then you repeat the count, maybe it's a falsely low count. You said clumps. If platelet clumps are present, what does it rule out?
Function defect.
Very good. So thrombasthenia is ruled out. Okay. Now, you said absolute count of neutrophils was low.
Yes.
But what is the differential here? Percentage wise?
So lymphocyte was 66.2%. And
granulocytes 29.8. Okay.
Thrombocytopenia could be false. could thrombocytosis reported could be false? You're doing a CBC and a platelet count is high, but it's falsely high. Why should that happen?
So if there is dehydration or sepsis, this can be high.
In iron deficiency, you have a high platelet. Why? What has iron deficiency to do with high platelets?
So because in iron deficiency there is hypoxia, and hypoxia releases erythropoietin. This is an agonistic reaction with thrombopoietin of platelet. So it increases platelet production as well.
In other words, the common automated machines that are used in most of the hospitals cannot differentiate many cells, but they can only go by size. So if the size is very small, they call it platelet. If the size is big, they call it a WBC. And if the size is in between, they call it RBC. Now when RBCs become microcytic, the counter calls it platelet.
Okay.
And that's why typically in iron deficiency or any microcytosis, you will get a apparent high count. And that's why again check. But how do you check? Can you check the count with a peripheral smear? In one smear, you may say 100 or 1000 platelets. How do you know that the platelet count to be assessed on a smear? And the answer is, for every one platelet that you see, the count could be 10,000 in a one large field, a large power field. So they count the platelets and the number of platelets into 10,000. So if you have a 10 platelets seen in one big power field, then you know it's 1 lakh as a platelet count, roughly. And that is why a platelet count on automated chamber must be also accompanied with a evaluation of platelet in the smear. But instead of saying adequate, they could say that in one power field you are saying so many, therefore they call it adequate. And I think that's the way platelet needs to be very carefully seen that. Same thing happens about RBCs also. When it's macrocytic, it could be falsely called as even a WBC, for example. But that's not often so because the cell size doesn't go so high, but cell size could go so low down in many microcytic. So platelets are not dependable on automated chamber.
So it's done today, so report is awaited. So we've done bleeding profile as well, so it's normal.
Okay. So what are you expecting on the bone marrow?
So the erythroid series will be normal, WBC series will be normal, and the megakaryocytes will be normal to increased megakaryocyte.
Okay. That is if your diagnosis is ITP. But you've done it to rule out leukemia.
Yes.
Okay. How will you treat this child? One second. How will you treat 7,000 platelet count?
Course of steroids.
Steroids. Okay, why?
To destroy the antibodies which is formed against the platelets.
Okay. So you are saying steroids because you have already done a bone marrow, that's why, or you are saying steroids in general? Can you give steroids to everybody without, can you give steroids to every ITP?
It's indicated more in like chronic ITP. In acute ITP, if it is mild cases, then we can observe and see.
Mild means what? 7,000 count.
Means based on the manifestations, if there are only petechiae, mild petechiae purpura, without mucocutaneous involvement, then we can observe and see. Then if there is mucocutaneous involvement, then we should consider IVIG more than steroids.
Okay. So what is the pros and cons of IVIG versus steroids?
It's a cost factor.
So IVIG is costly. What else? So then we should always use steroids, no? Then why even consider IVIG? Come on. So any contraindication to using steroids?
If
Sign of raise ICT. Here not, but if child is having hypertension or sign of increased intracranial tension, or child is very immunosuppressed.
Why should a ITP child have hypertension? No? So that's not the reason. So the reason for steroid is this only, no? What you just did in this child. So in that 1 in whatever chance of this being a malignancy, if you give a steroid without knowing that it's a malignancy, then you are harming that child. So it is made a rule that you must do bone marrow if you want to give steroid. Right? And you don't normally want to do a bone marrow because your diagnosis is almost always certain that this is ITP. So IVIG has gained precedence over steroid. But what is most important is your first statement that 7,000 does not decide whether you treat or you don't treat. It is the clinical manifestations, how severe is the bleeding, how that will decide whether you want to treat or not. Even that 7,000 is going to bounce back today or tomorrow.
I think, is the bone marrow a must in ITP? What's the general recommendation?
no.
And if hemoglobin is normal, if WBCs are normal, and only platelets are low, and the child is not sick, then possibly you need not do a bone marrow. Okay. More so if you see already a mega platelets in the peripheral smear. But if there is a doubt, of course, you will do it. But large number of times. So my question related to this statement is, can a bone marrow disease of any kind, aplasia or leukemia or infiltrative bone marrow disease, presenting with thrombocytopenia, will have only one cell line affected? No anemia, no leukopenia, only thrombocytopenia and a bone marrow disease. Is that a possibility?
Early presentation of, means it could be the first presentation of it.
Almost never, except one type of leukemia, which is extremely rare, and that is known as a megakaryocytic leukemia, where the story starts with platelet and then possibly involves other cell line. Otherwise, the commonest presentation is anemia with thrombocytopenia, with or without leukopenia. Okay. And then if it's a ALL, you may not have a leukopenia necessarily, you may have even a higher count, but with lymphocytic. So that is one. So as a hematologist, he would see once in his lifetime such a problem, so he would say always rule out with that. Then my next question is, can this patient be not treated at all? Neither IVIG nor steroids. He'll get well by himself.
So if there are minimal symptoms, not interfering with his daily activities, and he can follow up regularly, there is access to follow up, then we can wait and watch.
Okay. When would you wait without giving treatment at all? And the answer is, if patient comes a week or 10 days after the presentation and has not worsened,
okay,
then you are almost sure that he may not need treatment. Okay. Of course, like almost every other disease of this kind, which is self-limiting, but the super specialist may say, I've seen once, even thereafter he progressed. Now, he puts us a fear in our mind that this could happen. To me, it's almost like this may fall down any time. Yes, I'm right. And I've seen once it happened. So, I respect that finding, but I will know clinically what is happening. Okay. On the other hand, if it's a neurological situation similar, okay, there is a risk that it could involve respiratory muscles, he may go on a ventilation. So the neurologist would say that even if you see such a patient, self-limiting antibody-related disease, you would still give treatment, and the treatment would be IVIG as a choice. But if you want a cheaper drug, then you will better do a bone marrow tube route. But generally, when IVIG was not there, we were trained that you wait, most of them will be all right. But today, you cannot even risk life of an occasional, one in a lakh patient, which is correct. But when it's an ITP, when there's no mucosal bleeding, it's only a skin bleeding, when no new spots are coming, there is enough evidence that you could even wait and do nothing.
At what count will you give him platelet transfusion?
Sir, if there is life-threatening bleed, like intracranial bleed, then usually we give platelet transfusion.
So, in an intracranial bleed, if you give platelet transfusion, will it help? Why do you not give for this 7,000 count? It's very low, no? Why risk a intracranial bleed? Give it. Give platelet transfusion.
So on giving, there will be again premature destruction because it is antibody mediated.
So platelet transfusion is useless. So it is not going to help. So you would not give. Now, if, means theoretically, none of us has seen an intracranial bleed in an ITP. But theoretically, what is described, if there is an intracranial bleed, will the platelet transfusion save that bleed or what else?
Further bleeding. Further bleeding will be prevented.
So they talk of even splenectomy, emergency splenectomy during that intracranial bleed under cover of a platelet, continuous platelet infusion. And the moment you do a splenectomy, the platelets will stop, the count will rise. Okay. So when do you use platelet transfusions? Do you use it in dengue? Suppose there is a child with dengue. Would you use platelet transfusions there? Come on.
Until and unless there is any bleed or the platelet goes to a critically, critical
What is
level.
that critical level?
10,000.
10,000.
Huh?
10,000.
Who decided 10,000 and why? So in dengue, bleeding is due to platelet or due to something else? Major bleeding in dengue is due to what? So it's a mixed phenomenon. It's not just platelet. It is coagulation factor also, right? And again, what is the mechanism of thrombocytopenia in dengue? Is it production or is it destruction?
Destruction.
So what's the point of giving platelets? So the similar logic like your ITP, that it's not really going to help, it's going to get destroyed. So of course a very sick child who's almost dying, people may give, but otherwise by and large even in dengue, platelet transfusions are to be reserved, right? And it's a multi-pronged, more important is your coagulopathy rather than only the platelets, right?
One of the report slides that he put up, down there the laboratory had written, this report relates to only this sample. So he is not responsible whether you had a clot there. Okay. I was most interested to see most of the laboratory x-rays now I do clinical correlation. Okay, don't involve me if I'm wrong. I was quite impressed by that last line which said this report relates to only this sample, not this patient. Okay, this sample of this patient. I think that was the reason they must have seen that. You go back and said, no, you reported low, but he was all right. No, that was your sample, that was your problem.
A splenectomy in ITP, they said that even in surgery, no sooner you put a clamp on the splenic artery, the platelets start rising right from that moment. So immediate is the. There is a child of, let's say, 2 years, is brought from some fever, and platelets are 8 lakhs. Is recovering. You repeat it, next day, it's 8.5 lakhs. Do you treat this child? He is improving. Do you treat thrombocytosis in a child like this, or you don't treat? He may land up with clotting problem for all you know. I don't know the right answer. I have not treated, but I have seen 1 or 2 patients who had a high platelet count. They were relatively small one. This child was put on aspirin for a period of about 3 to 6 weeks and later on tapered off. I haven't seen that later, but this is just for you to look into it and let us say what are the current concepts. Maybe 8-9 years back, current concept about so-called thrombocytosis in an otherwise normal child.
Commonly today they do platelet immature fraction, a good monitoring ability to say whether the child is improving or not. Much before the new spots stop coming, you have a PIF gradually going up, telling you that immature platelets are coming up more and more. So I think that's a good test that most of the laboratories today do platelet immature fraction. So I think mention that also. And then on such patients you must know what are the indication of platelet transfusions, what are the problems of platelet transfusions, how you need to have a fresh platelets, all those things I think would be asked on such a patient. So take a note of all those, right?
Anything else? Okay, fine. Any questions?
I think you brought the photographs today. Good.
Okay, so I think we'll stop here. So thank you everyone for participating in today's class. And once again, those who will watch the recorded version of this class, we want to tell you again that for the few weeks the hall is under renovation. So since there's no internet connection in this temporary hall, we have a recorded version being put up, and hopefully in a few weeks we'll be back with the live relay. So we meet once again.
Quick summary.
Okay. So a quick summary of 2 cases. So today the first child was a older child who came with 4 days of fever. On details of the fever, he was found to have high fever but playful interfebrile, and the fever settled by the 4th, 5th day, suggesting that it was a self-limiting viral fever. Following that, he developed multiple purplish red spots all over the legs first, followed by trunk and hands also, along with swelling of both lower limbs and then joint swellings. So as the disease progressed, it was obvious that rash and swelling together would mean a vascular origin, and therefore this was a vasculitis of some kind coming up. And then the subsequent joint involvement, etc., made it very clear that this was what is known as IgA vasculitis, earlier known as Henoch-Schönlein purpura. The purpura often is palpable. In this child, it was not very sure whether it's palpable, and now this child is recovering. We discussed that the definitive diagnosis is only by a skin biopsy, otherwise all other investigations are supportive, and it's a non-thrombocytopenic purpura. The second case happened to be a 5-year-old who came with spontaneous ecchymotic spots all over the body, and we discussed between bleeding and a coagulation disorder, and we said why it's more likely to be a bleeding disorder because there are no deep bleeds, joint bleeds, etc. So less likely a coagulation disorder. And then again we went on to discuss what are the what are the diagnostic criteria for ITP. So apparently a well child, happy child with purpuric and or ecchymotic spots would qualify for a clinical diagnosis of ITP. We discussed about treatment, that if the child is stable, there is no compulsion to treat. If the child has come 7 to 10 days after presentation and is stable, again there is no compulsion to treat. We discussed 2 modes of treatment, steroid and IVIG. In steroid, you have to be very sure, either clinically or by investigation, that you are not dealing with any bone marrow problem, right? So these were the 2 cases that we saw today, and we meet once again next Thursday, 6 p.m. Once again, we thank Aristo for their educational grant to help the webcast of these classes. Thank you.
You are very lucky to see 2 purpuras on the same day. Okay, different etiologies, diagnosis made clinically. You may just write down 2 columns.